Limpopo Health launched its Rural Health Matters outreach program in a drive to raise awareness and action against Urogynaecology, urology backlog. The department also wants to see a skills transfer to clinicians in the province. A urogynecologist usually manages the clinical problems associated with the dysfunction of the pelvic floor and bladder, among other things. While pelvic floor disorders affect the bladder, reproductive organs and bowels. Health MEC Dr Phophi Ramathuba joins us now to explain more about the program. Dr Ramathuba, it's always good to speak to you, and certainly a lot of these initiatives that you're carrying out are pioneering. Talk to us about this particular program.
Afternoon, Hugo, and afternoon to all your viewers, and thank you for having us. As a province, you would understand, I always tell you, we are a rural province, and it's very difficult to attract rare skills in a province like ours. That is why the only urogynecologist in the province, Dr. Mwaba, is always understanding the vision, and he shared the visions that we do have as a department towards making sure that there is access to these scarce skills resources towards especially the rural women. Now, during the Women's Month, which is August, the National Women's Month, we felt as a department, and I was saying to him, this department is led by a woman, and the women of Limpopo must feel the impact of a woman leading them. And therefore, we really need to come up with an initiative that will address some of their challenges. And one of those issues are some issues that you might underestimate, because when you are more resourced, you would not understand what the rural women go through on a daily basis. So that is why, for example, when you look at some of these urogyne challenges that faces our women, I remember one of the patients that was just operated was sharing us a painful story that she could not even go out of her household for more than almost 18 months, because since she started having this problem of failure to retain urine, it was very difficult, because the moment she feels the edge, by the time she reaches a bathroom, she has already messed up herself. And this also affected even her mental state. She ended up locking herself up, because people within the rural villages do not understand. You will always be blamed to say, probably it's because you are promiscuous, you've been sleeping with different men. So all sorts of things that you are being labeled to say you are not hygienic, you don't take care of yourself. Divorces happen, in-laws calls you names, you could be a witch and all that. So we felt, let's go out to the community. And what we are happy, since appointment of Dr. Mwaba, when he came back from Stellenbosch as a Urogyne, we have seen the awareness and the campaign that he has been doing to the community, working with us. People now understand that when you have this problem, you need to go and see us. Now, the danger, and which is also a positive at the same time, when people start to be aware that this is a condition that can be manageable, they then start to come to your clinics and hospitals in numbers. Now we realize we have got a huge backlog because of this campaign and the awareness. Now we then have to come up with another way. So hence we still appreciate this initiative, which attracted international professors who are Urogyne, who has been mentors for Dr. Mwaba. For instance, Professor Kruger, who is there now, even today, since Thursday, they've been in our theaters trying to clear this backlog. We had a backlog after our campaign up to April, but now after this whole long weekend that we've been working throughout, we have realized that our backlog would be probably somewhere before November. We will definitely be done with the current cases that were there in the province.
Dr. Ramathuba, talk to us about those numbers in the backlog. What numbers are we talking about?
When we look at the numbers that we have, you are not looking at something that is below 100. But if you look at by yesterday, just for this weekend, we had already done around 26. Now, that tells you that that number, it's gradually reducing. The danger of me telling you that the backlog, it's the exact, to give you the exact number of the record that we have now, is that we are still having people, right now when I'm doing this interview, which we must thank you, there's somebody who is watching and they have got a similar problem, or they've got an aunt with a similar problem. Tomorrow we will see them coming to our facility. We had the MEC talking about this. We want to see Dr. Moab. So that is why you could see that sometimes the backlog, when we tell you we have got so many, and then later on you realize there are others, it's just because people were not aware that these conditions can be treated and can be manageable if people present to our facilities early. So for me, what is comforting me is that people now are aware, and we know now that by November, when we look at our cases, we will be done with the ones that we know about. We will start to be looking at the new cases that are going to start to come. And remember, we are not only doing the Urogynaecology cases. We have been in Waterberg the whole weekend, from last week, Saturday, up until even today, where different types of specialists, other visiting professors like Steve Machize from UOF's Free State University, Professor S.S. Golele from the SMU, and many others from as far as Lady Smith. They are here in the province from UCT because we made a call as a province to say, anyone who has got the skills that our people need, I don't have money to can pay you, but I've got patients for you to can operate, and your payment will be job satisfaction. And believe me, many clinicians out there, they make that call and say, MEC, we're available. They've been spending the weeks, the whole week, and some a weekend, and clearing this surgical backlog. You're looking at orthopedics cases that we've done. You look at ophthalmology cases that we've done. You look at pediatric surgeons, the kids, plastic and reconstructive, the cleft palates that we've operated. All those cases just in Waterberg, in just 1 week, we've been able to perform more than 438 cases. We are still going today. We will finish midnight.
Well, you must allow me to commend you, certainly and your colleagues, for those numbers. It also then begs the question that these operations, the surgeries that are carried out, come at a cost. Are the patients, particularly in the rural, poor communities, having to pay for the operations?
Look, when you are visiting the state facility, what we do is to assess your financial status. And we categorize you from H0 to H3. Meaning, if you are working like me and you, we are going to charge you and claim from your medical aid. The difference between us and the private sector is that our tariffs are far much more lower, and the medical aids are happy when patients visit the public service. When you are not working, you are unemployed, we expect you to come up with an affidavit as an evidence from the which you could have done from the police. And if it shows that indeed you are not working, we will not charge you anything. If you are a pensioner who depends on SASSA, you must bring to us that SASSA certificate. It will prove that you are not working, you are a state patient, we will not charge you. If you are a pensioner who is a former MPL or a former principal or inspector, we will charge you a certain fee, which is lower than the one who's working, but which is not free like that. So what we're trying to say is that this is what the National Health Insurance was supposed to be doing, wherein those that have, like me and you, subsidize those who cannot. If you look at how much will we spend as a state if we are to take this patient, to take them to a private facility and say, let these cases be done. For instance, one old lady that I met yesterday after the operation, she's a pensioner. She said to me she went to a private hospital and asked for quotation just for the theater time. They wanted 200,000 rand. And this is a SASSA grant patient. She can't afford that. And when she comes to us, we're not going to charge her a cent because she doesn't work, she's a pensioner, she depends on SASSA. So this is some of the programs that we are doing as government, which the people out there need to know so that they can access this quality health. But I must say, we will not have achieved this if we do not have these selfless clinicians. These professors and these doctor specialists could be making millions. I've just given you some of the figures. Just to work from Thursday to Sunday, it will be a lot of money for them.
Dr. Ramathuba, we've run out of time, but certainly appreciate your time coming on to the show and must commend you for all the work that you and your colleagues are doing out in Limpopo. Dr. Phophi Ramathuba with us this afternoon. Incredible work that clinicians and other doctors are doing pro bono to help many of the disadvantaged in Limpopo.